I'm moving forward every day, Jesus. I just let him lead the way every second, every minute, every hour of the day. I'm moving with Jesus every day, see, 24/7. With Jesus every day, see, 24/7. I'm moving, see, with Jesus. I'm moving, see, with Jesus every day.
Genesis chapter 1, 26 and 27 reminds us that God made man in his own image and likeness, male and female created he them. He took the time to separate male from female, to differentiate the difference between male and female, because there are differences. There are some things that affect women specifically and uniquely and exclusively. And of course, there are some things which affect us men. And to discuss the whole issue of prostate cancer. This is for men only, but women, you are invited to join in the discussion as well, as I engage urologist Dr. Kirk Gooden. Thank you for joining us today on JC 24/7. This is your first time, and we are happy that you could join us, not only in Trinidad because you're from Jamaica, but even on JC 24/7. We want to talk about prostate cancer. How bad is it in the Caribbean? How bad is it in Trinidad? How bad is it really?
Well, prostate cancer is a very, very, very common disease in the Caribbean. In Trinidad, it's actually the most common cancer in Trinidad in men, and it's the most common cancer when you look at, even cancers that affect women. Breast cancer, cervical cancer, it's even higher than that. Jamaica, it's the highest cancer in men in Jamaica. In Barbados, as a matter of fact, the Caribbean has one of the highest incidence of prostate cancer in the world.
You're kidding me. What is responsible for that? Is it attacking a certain race, a certain ethnicity, or what?
Yeah, well, there are certain risk factors that are associated with it. We have what we call irreversible risk factors, and there are some that we refer to as reversible risk factors. Right. The irreversible risk factors, being an African male, put you at risk.
Right.
Also, as you increase in age, your risk increases for getting prostate cancer. And also, if you have a family history of prostate cancer, your risk also increases. So those are the three irreversible factors.
Okay, so just being
an African, you're at risk. An African male, you're at risk.
Wow.
Even we look, for example, in the United States, and when we look at prostate cancers and compare it between, African male and Caucasians, the African male, they're at a higher risk of getting it. And when they do get it, their cancers are ridiculously aggressive.
Wow. So is it something on pigmentation, something on makeup? What do you think?
Yeah, well, they believe it has a lot to maybe do with the type of genes that we may have. Okay. Now, they also believe that there may be environmental factors that are involved, because there have been studies that have looked on men, Japanese men, and Japanese men in Japan, they would have a low risk of prostate cancer, but whenever they travel to the United States or the Americas in general, their risk actually increases. So they believe that the environment has a lot to do with it. Right. They have considered diet as one of the possible risk factors, but a lot of the studies that we have looked at haven't actually shown any close relationship with diet and prostate cancer. Okay. One of the big studies that they did, they looked at vitamin E and selenium, and it actually didn't show that it decreased the incidence of prostate cancer by taking vitamin E and selenium. Another thing was lycopene. Right. Initially, lycopene from tomatoes, right? Initially, it was suggested that if you eat, tomatoes, then with the lycopene from the tomatoes will help decrease your incidence of prostate cancer.
So I've been eating tomatoes in vain. Is that what you're saying?
Well, I am very sorry to say, but that's the actual truth, because studies,
at least as it relates to cancer.
You're right, as it relates to the prostate cancer, right? Because more recent studies have suggested that it actually has not decreased the incidence of prostate cancers.
Yeah, tomatoes and pumpkin seeds and all those things.
No. So they haven't had any studies to really to support that. They have actually, looked at, other things like a male's ability to ejaculate very frequently, and
Right.
when they do that, they could decrease the incidence. But I mean,
So that's not true, is it?
Well, the studies have suggested that is a possibility, but I
Doc,
mean,
you're making some men disappointed here. You're getting some guys angry because I thought the studies show that the more a guy ejaculates.
well, that's what right. So I'm saying that's exactly what the study shows.
Right.
All right. So I mean, based on that, a man could believe that he could ejaculate more. I start to have a bit of doubt where it's concerned, but
okay.
I have to just agree with whatever the study has.
Oh, you agree with it?
Yeah. That's what the study is
Okay.
saying until they come with something.
So some guys are happy now, as you're saying. That.
Yeah, very, very happy. I can tell you that.
But why would that be necessary? Why would that happen?
Actually, I'm not too sure what's the relationship of
Right.
increased ejaculation has to do with decrease in prostate cancer.
Testosterone level or something like that?
Right. Well, that has nothing to do with testosterone. As a matter of fact, I mean, that's a big controversial thing.
That's another controversial,
No, whether testosterone actually causes prostate cancer. And when they look at, studies, it has not proven that testosterone has any relationship with prostate cancer.
Right.
However, if a patient is going to be placed on testosterone, there's certain tests that needs to be done just to ensure they don't have prostate cancer. For example, PSA or DRE, just to rule out prostate cancer.
Okay.
And that's important before you put anybody on testosterone. But so far, there's no tests, no studies to suggest that if you place somebody on testosterone, you place them at risk. As a matter of fact, even patients who have prostate cancer and you put them on testosterone, that does not actually increase their risk of having a poor prognosis.
Okay.
A lot of studies have shown that.
Okay.
But having said that, the American Urological Association, they have said that, well, they are not actually supporting such thing. But that has to be a decision between the doctor and the patient.
Okay. Who are the persons that are most likely at risk or most susceptible to prostate cancer?
Well, so as I said before, being a black man, being an African, African ethnicity one.
Good.
As you increase in age.
Right. So when you say age, are you talking about 30s, 40s, 50s? What?
Right. No, so actually, prostate cancer is commonly diagnosed at age 68. And that's the age it's commonly diagnosed.
Right.
However,
68.
68.
It's interesting that you have a specific number. Why not 60s? 68.
Right. So as they get older, it increases. But when they do the study, they notice that most men, that's what the age that they are diagnosed.
Okay.
However, having said that, I have seen young men in 40s, as early as age 45 or so, having prostate cancer. Now, if you have a strong family history and you're an African male, it's advised that you get screening early.
Right.
And I advise that patients at 45 years of age should get a screening for prostate cancer, especially if they're African and especially if they have a strong family history of prostate cancer.
Okay.
Because the earlier you pick it up, the better it is for you to actually diagnose it when it's more localized, where it's now easy to treat, to give you a better chance of being cured.
When you say strong family history, are you talking about father, grandfather, or brother, sister?
Right.
Sibling?
So if you had a brother who has prostate cancer, or your uncle or your grandfather or something like that, yes, you are at a higher risk of getting prostate cancer.
Okay. All right, and you should get your test.
And you should get a test.
At what age should you really start doing?
As I said, if you have risk factors, I suggest 45 to be the best age to start do your screening.
Right.
But generally for the general population, male population, I would say 50. But if you have a strong family history, I suggest that you get it earlier at about age 45.
What does the screening entail?
Well, the screening actually involves doing a PSA, all right, which means prostatic specific antigen. And this is an enzyme that is secreted specifically by the prostate itself. No other organ secrete this enzyme. And in prostate cancer, this PSA actually increases. And we use that as a guide. And then if the PSA is elevated, we decide now we may have to do a biopsy, a prostate biopsy for this patient.
Okay.
The other thing that should be done is what we call a digital rectal examination.
Which a lot of guys fear.
Right. And in my practice. There's a lot of guys I would have gotten different reactions in doing a DRE. Some, because they want to know what's going on, they will allow it. But for most part, not many men want like the whole idea of another man or a female for that matter, to put their fingers in the back passage. But what happens is that the PSA could be normal. And then when you do a DRE, a digital rectal examination, that's when you realize that there's an abnormality with the prostate. Because when patients have prostate cancer, they could have changes in the prostate that when you feel it, the prostate could feel hard, it could be irregular, or it could feel a specific nodule on the prostate. And that in of itself could be a sign that you may have prostate cancer.
What is supposed to be the normal texture of the prostate?
Well, usually the prostate should be smooth. It shouldn't have any nodules on it. And it should be more indurated, maybe firm. But if you feel a hard prostate, it's a high probability that the patient has prostate. So the prostate shouldn't be hard.
So once it's hard,
then there's a high suspicion that this patient may have prostate cancer.
You mentioned PSA, normal PSA. What is normal PSA really?
No, so I don't talk about a normal PSA. When you look at the blood forms, they do suggest that 0 to 4 may be normal. But PSA is like a continuum. As the PSA increases, your risk of having prostate cancer increases. For example, if you have a PSA between 4 to 10, there's a 25% chance that you have prostate cancer. If your PSA is greater than 10, there's a 53% chance of having prostate cancer. And as it increases, as you can know by now, it will definitely increase. However, between 0 to 4, some men still can have prostate cancer. And there have been studies, one particular study called the Prostate Cancer Prevention Trial, when they analyzed patients who had normal PSA and DRE, they went ahead and did biopsies in these patients. And as high as, as low as 15% of that group of patients had cancer, and some even had aggressive cancer. So, so even though the PSA is normal, and the DRE may be normal, there could be a risk. And that's the reason why, as I tell people, the PSA is not specific for prostate cancer. There are other reasons why a PSA could go up. You could have an enlarged prostate. That alone could make the PSA go up. If you have inflammation of the prostate, that also could let make the PSA go up. So we have to look on several factors. And as I say, if patients are at risk, if they have family history, if they are Africans, or of African origin, I should say, these patients, then you have to talk about doing screening for them. Maybe do the PSA like once per year, once every 2 years. And if you see a trend like the PSA, what we call the PSA velocity, this is the speed in which the PSA increases. And if it increases by a certain speed, then we can suspect that this patient may have prostate cancer. So there's several things that we use to help us to decide. And that's the reason why it's best for a patient to see a urologist as opposed to going to a general practitioner. All right? Because there are other things that we look at. And then we put everything together. And I think we may need to do a biopsy for this patient.
Good. Doc, we take a break. We are here with Dr. Kirk Gooden as we talk about men's issues. Prostate cancer is the subject of our discussion. We will be right back. Get your men friends and get your father, your sons, your brothers, your cousins, and tell them to tune in as we continue our discussion, man to man.
Beautiful Lord, wonderful Savior, I know for sure all of my days are held in your hands, crafted into your perfect plan.
I'm here with Dr. Kirk Gooden as we talk about prostate cancer, man to man. And Dr. Gooden, we were talking about the whole question of PSA and DRE as not being necessarily firm indicators as to whether you don't have cancer. Could you elaborate a little bit more on that? Because I think some of our listening audience, members of the listening audience, may have missed it. Just to be clear, are you saying that even if you would have done a DRE and you came back fine and the PSA level was normal, it does not necessarily mean that you don't have cancer?
Right. So, I mean, so far as men, that's what we have.
Right.
As doctors, as scientists,
right.
You know, that's what we have so far. And we have been using it as a guide.
Right.
So
after putting a man through the humiliation, if you like, of the DRE, and he comes back and says, at least, okay, I want to go back there for the next year.
Right.
It still doesn't guarantee anything.
I mean, you see, we have to be honest with our patients.
Okay.
And, you know, as doctors, we need to tell them the truth.
Right.
And we have to let them aware, because you see, what could happen is that you do a PSA for a gentleman, it's normal. You do DRE, it's normal.
Right.
And then what happens subsequently? 2 years down the road, he would have gone and done the same thing. Turns out that he has prostate cancer. Then what? The other doctor looked like, you know, what he was doing, because I went to a doctor 2 years ago.
Right.
So you have to advise the patient, you know, that these are the only tools that we have, and we also have other tools that can be used, but they're not foolproof.
Right.
You know, so I mean, this is what we have for now, and this is the best thing that we can do now until we come up with other methods. You know, we could try other methods to see, but this is what we have.
Right.
And these are just guides.
Right.
You know.
Okay. So I'm sure there are other ways of determining whether a person has cancer, or perhaps there are symptoms of prostate cancer other than doing the DRE and the PSA. What are
Right.
some of
So,
the
I mean, so usually you do the PSA and DRE, and that's just a screening method.
Right.
And so these are patients who are asymptomatic, but maybe because they have African origin, maybe because they have a family history, they decided they want to, you know, to go and get screened to see if they have prostate cancer.
So to speak.
Right. However, I mean, unfortunately, a lot of our patients that we see in Trinidad present with symptoms.
Right.
And usually when they have symptoms, oftentimes it suggests that they are maybe advanced. The symptoms essentially could have what we call lower urinary tract symptoms, where they have difficulty passing the urine, or they find themselves peeing very often, more than the usual, or they find the stream not so good. The stream, you know, a couple of years ago it was going like that, but now drop it down on my shoes, wetting me up.
Right.
So, I mean, if they have symptoms like these and they go to a urologist, one of the tests that we have to do is rule out prostate cancer. Because, you know, what happens is that when we urinate, the urine is stored in the bladder. But as the bladder contracts, the urine passes through the urethra, which is a passageway through which the urine passes. Now, part of that urethra, it passes through the prostate. So, as the prostate enlarges, then you can have problems with passing urine. It could enlarge because of just prostatic enlargement, or it could be the fact that because of cancer. So if they have low urinary tract symptoms, then we will check for prostate cancer. The other symptoms they could get is they could have loss of appetite, they could have weight loss. A lot of patients, they may present with lower back pain, and they may think it's arthritis and stuff. Sometimes they end up going to the orthopedic doctor. And then when the orthopedic doctor checks them, they may do an MRI of the back, and they realize the spine not looking so good. They look at this person may have cancer. And then one of the places that prostate cancer spread commonly is to the spine. So now they will refer this patient to us. Then we'll have to do the PSA and stuff. So, I mean, but at that stage, it's maybe already spread. So essentially, diagnose it now is just a matter of trying to control it now to prolong the patient's life.
Let's take a detour just a little bit, because you mentioned the urine and the passage and stuff like that. Well, I've heard more women than gentlemen, but I'm sure there are men as well who do not like to get up at nights to pass urine, and they don't drink much water. How safe it is to store urine in the one's bladder, and how long should it be stored there?
I mean, that's a good question. There's no specific time limit that has been allocated to how long. But my advice to patients is that as soon as they feel as if they need to urinate, you should empty the urine, because the urine is a fluid filled with waste products. Remember, one of the purpose of the kidney is to filter the blood system of all those toxic and waste products. And then as the kidney filters it, it creates urine.
Right.
And then that urine is filled with waste products. You don't want to be storing your urine long. You're on the risk of increasing your bacterial load and put yourself at risk of infection. So my advice is that as soon as you feel like you want urine,
right,
where it's sociable, acceptable,
yeah, I hear you.
I will not advise, and you will then pass the urine. But as soon as possible, I will encourage them.
Can the condition or the color of the urine be an indicator as to what something's happening?
Well, so the color can be an indication of maybe something happening. For example, if a urine looks very concentrated, it could mean that the patient is dehydrated. Then certain color of the urine could determine like the type of food that you're eating by the color of the urine, the smell of it. Sometimes I know if you drink coffee, sometimes when you pass your urine, urine actually smell like. So the smell of the urine, if it's foul smelling, could suggest infection. Sometimes the urine may have in blood. And that's one of the other ways that these patients who have prostate cancer could present. You could actually see blood in the urine. So the color of the urine looks is important in helping us, to make diagnosis for patients. And if you have blood in the urine, it don't necessarily have to be prostate cancer, but it could also be cancer from the kidney. It could be cancer from the tube that leads from the kidney to the bladder, or cancer within the bladder itself, or cancer within the urethra.
Wow.
So
you're kidding.
When you have blood in the urine, and it's not all the time you'll see blood in the urine. I've seen patients come to me who have went to the insurance company. And they would have done they went for a general checkup. They would have done a urine dipstick, and they would have found blood. So that's what we call microscopic hematuria. So they wouldn't have seen it. However, so when this patient comes, they need to be investigated just to make sure that they don't have any cancer anywhere along the urinary tract.
So you could have blood in your urine without knowing that there's blood in the urine.
Right, exactly. And that's why we do general checks. You go and, I know they have this executive medical check. You could go in and do everything. Because sometimes you're normal. You're looking good.
Good.
How many times you drive in a car, the car looks good. And then you go up the road 2 miles down the road, the car breaks down.
That's right.
And then you realize something was wrong. But you didn't know because you don't routinely check. And that's the same thing with our body. Things can be going on in our body. And because we don't routinely check, we don't realize. But if we do it, sometimes we can pick things up earlier, and then hopefully we'll be able to cure it.
What about painful passage of urine?
Well, so that as well is another presentation for prostate cancer, painful passage of urine. If they do have that, though, we have to think of other things, because it could be just enlarged prostate. It could be like a stricture, like a narrowing in the passage, actually could also cause that. So they need to be assessed properly and see, what could be the possible, problems why they're having that.
Now that you've gotten some of our audience members sufficiently scared, what are some of the treatments we can use? Right,
so it depends again at the stage in which these patients present. But the treatments, there are a multitude of treatments, and they include surgery, which we call radical prostatectomy, and that's usually done for patients who have localized prostate cancer. You also have radiation available that can be used to treat patients who have localized prostate cancer. It could be what we call external beam radiation, or it could be what we call brachytherapy. Now, brachytherapy is a form of radiation where the seeds are implanted into the prostate, and it's usually given to patients who have low-risk disease. All right. The other treatment available, we have hormonal therapy. That is usually given to patients who have advanced disease or patients who have already had spread. And there are different hormonal therapy. Actually, it's divided into medical or surgical. You can move a person's the tissue within the testicle. All right, and as a treatment for patients, or you can give them, injections or tablets that could treat. You also have chemotherapy available, and again, that's usually given to patients who are advanced, but that's available as well. So there are a multitude of treatments available, and it just depending on how the patient presents and what stage they are will determine what treatment the patient gets.
But there is help.
There's help.
Yeah. And of course, early detection.
Right, that's the best thing.
It's to the person's advantage.
That is the best thing. So I advise patients, men, especially if you're African origin, and also if you have a strong family history, I advise get screening. It's better we pick this early and deal with it.
I've been told that prostate cancer is one of the slowest growing cancer. Right. Or true that?
Well, it can be slow growing. Right. The problem, one of the problems we have, we don't know which one will be slow growing, and we don't know which one will be aggressive. Sometimes the aggressive ones will give us ideas. But I've had one scenario. There is a prominent urologist in UK that was diagnosed with prostate cancer. January, he had a PSA done. The PSA was less than 4. 4 months down the road, he was having abdominal pain. When they did an ultrasound, they realized he had a growth on the liver. They didn't show where it was coming from. Somebody suggested, why not repeat a PSA? And when he repeated his PSA, it was over 400. And it just turned out that he had aggressive prostate cancer. Right. No, that is rather scary.
Wow.
And that's so he did the right thing. He got screening done. He got a PSA. PSA was okay. But there was some aggressive thing brewing there. And that's the problem. We don't know who will be indolent or who will be aggressive.
Right.
And we try to develop methods, blood tests. Sometimes now we have what we call multiparametric MRI that we use to try to decide if these patients have aggressive cancer or not.
Good.
But it means that these patients have to follow up closely. And you know.
Apart from being a urologist, you're also a Christian.
Yes, I am.
What part does God play in helping a patient to cope?
Man, that is extremely critical. I wouldn't have been here if, you know, it wasn't for God. You know, and so one of the things that I do is I recognize that God is critical for my success. I mean, I'm successful because of Him.
Right.
And so, you know, every time I meet my patients, I find it a privilege. I use the opportunity to actually encourage them, you know, spiritually. You know, I do pray for some of my patients. As a matter of fact, one of my plans when I make plans for my patients, you know, you have the history, physical examination, assessment, and plan. One of my plans is prayer.
Okay.
There are things that men can do.
Right.
But there's a lot of things we still can't do.
I hear you.
And we need God to make that possible.
Good.
And there are times when patients have advanced disease. We can do so much and no more.
Right.
But with God, nothing is possible.
I tell you.
So I've always encouraged my patients, pray, trust God. This is what we're doing. This is what we can do. But trust God for your complete healing.
Wow.
And I leave God up to that. So God is critical. It's critical to my existence. It's critical to our existence. And this is the only reason why I am what I am today, because of Him.
Have you had any specific experience where God intervened and helped a patient?
Oh, well, I remember, well, as you know, I'm from Jamaica, and I remember there was this a particular guy. He was a Rastafarian, or you want to call him Dread. He had a little girl that was, I think she was about 7 or 8 years of age. And she had an umbilical hernia that was very difficult to go down. She went to a previous hospital, and they were trying and couldn't get it down. All right, so they sent the patient. So when I saw the patient, I, you know, took my normal history, and then was about to examine the patient. The father said, "No, she having a lot of pain." I said, "Sir, no, I have to, you know," and things. So and then, you know, by the time I went and touched this little girl's abdomen, that swelling just disappeared. The guy, I mean, the Rasta guy, he jumped up off his chair. He was like in amazement, you know, because all this time this thing went down. But it went down, and I remember telling him, boy, God just did something special. But the little girl was fine. We never had to do anything. She was totally fine. And we just bless God for that.
Amen, amen.
So that's just one of the many experiences that...
So you are a gifted urologist.
Yeah, boy. Yeah, man, thank God for that, man.
And thank you for joining us, Doctor. I've been blessed just by your being here and for the experience you've had. I know we couldn't save everything, but we're happy for what we were able to experience so far. Yeah. I'm sure you would want to share your phone number. We would, so folk would want to contact you at some point. We have it posted on the screen. We are speaking, or have been speaking here with Dr. Gooden, Dr. Kirk Gooden, a urologist, man to man. He is discussing, or he has discussed, some of the things that happen inside of man. But I think what's more important is for the man to be inside of God. Jesus says, if any man is in Christ, he's a new creature. All things are passed away. Look forward to that day when we shall be transformed. With all due respect, there will be no more need for any urologist, because the great physician will welcome us back. Thank you for taking the time to be with us today. We look forward to having you once again on JC 247.